This is an X-ray lower abdomen and pelvis of a skeletally mature patient. I can see some metallic density or hyperdense areas in the right lower quadrant.
You can ignore those. You can, you can ignore that. That's an incidental finding.
Okay. So in the pelvic region, I can see a hyperdense area in that is abutting the pubic bones. I mean, it is intra-abdominal, but it is in the lower half of the pelvis. Rest of the visualized abdomen and the visualized gas shadows appear unremarkable. On viewing the bones, I can see that grossly the visualized spine and sacrum appear unremarkable. However, the pubic bone, the left pubic bone appears maybe eroded. It has lost its cortical contour superiorly, and no other significant bony abnormality can be seen. Keeping in view this pelvic region mass along with pubic bone abnormality, I'm considering it is in the anterior half of the pelvis. Maybe some mass lesion that is eroding the bone, or maybe a large lesion that is causing pressure effects on the bone. I would like to see a CT scan of this patient, maybe a contrast enhanced, preferably a contrast enhanced CT scan. The left SI joint is also, it has lost its normal joint cavity and maybe slight sclerosis. But rest of the film appears, rest of the bones appear unremarkable. So,
yes, very nice description. For the X-rays, the take-home message is they will give you a film with some positive finding at the periphery of the film, and always review the periphery very carefully, and always look for the symmetry. Allah Pak has made two sides so that you can always compare and pick the pathology, right? So yes, this bone has, cortex is completely gone. So you are right that this finding is picked up nicely, and nobody would expect that you gave a diagnosis and you approached it well, and the differentials were fine. This is very smooth and balloon-like, so this was distended urinary bladder. But I mean, always give both the differentials, that this can be this and this can be this. So, this film is passed as far as exam is concerned. So what we did that we did MRI of this patient. I hope I'm looking at the same patient. Yeah. So wait. This is post contrast. I will show you stir images only.
Okay,
to save the time, and then I will scroll. I'm going from anterior pubic symphysis to posteriorly.
Okay, ma'am. So these are stir coronal image, the same patient. So I can see a hyperintense lesion that is involving the pubic bone and left pubic bone. And can I see the lesion again? Can you scroll again, please?
Yeah, sure.
There are some abnormal signal intensity areas in the adjacent muscles as well.
Yes.
So
nice pick.
Rest of the other side of pubic bone and symphysis appear unremarkable. So no intra-pelvic pathology may touch. Okay, there are abnormal signal intensity areas in the sacrum as well as the iliac bones. On the both sides of sacral iliac joints, on both sides, on right and left side.
So fine and nicely done. So they would just like to see your approach, and what you said, that CT scan, that was perfectly fine. So after the CT, because they already did MRI, the orthopedicians, but unfortunately I don't have CT. But then you can always say that I see two areas of abnormality, so this can be metastasis. And approach is that we should do CT scan to look for the primary pathology, and also the bone scan to look for the multiplicity and rest of the osseous skeleton.
Okay, ma'am. Right? Can we get an infective etiology like tuberculosis and differential like tuberculosis sacroiliitis and maybe involving the bones and joints?
But tuberculosis would not cause a large retic lesion with cortical destruction. And it will not be multifocal, one area here, then right sacrum, then left sacrum. The iliac bones are normal. This enhancement is there. I don't remember that. This is actually in the iliacus bilaterally, right?
Okay. Yes, ma'am.
Provided with a X-ray chest frontal projection in a adult age patient, which shows that there is adult age female patient, which shows that there is a well-defined rounded peripherally placed opacity in the left lower hemithorax, and this opacity has smooth inner margin and a broad base with the pleural surface. There is it is continuing above in form of lobulated pleural thickening up to the level of the mid chest wall on the left. I cannot see any differential density, any area of calcification within this opacity. The underlying ribs in this area appears somewhat deformed, the posterior ribs. Other than this, I can see that there is mild cardiomegaly. Contralateral lung, right lung is normal, and right CP angle is normal. Bilateral apices are normal, and bilateral hilum shows few hyperdensities, but they are insignificant. So I am thinking about left-sided pleural-based mass or multiple masses which are pleural-based, and keeping that in view, I'm thinking about pleural metastasis, because these appears to be multiple, extending up to the level of clavicle. Further, I would like to know if there is any history of primary. If there is, then my diagnosis of pleural mets would be confirmed. However, other possibility of some further, I can perform CT scan to further characterize these areas.
Yes, I will show you CT scan. I have CT scan, but can you see any other abnormality on this X-ray?
Sure.
So when you look at the X-ray, you have seen that there is something in left lung pleura, right? Yes. So, and you thought that it is aggressive. So what other structures which you look at?
I would like to see I am looking at the bilateral breast shadows.
Okay, you have seen the breast. What else you would look for?
Other than this, I am looking at the bones. Visualized clavicles are normal. I have as mentioned that the ribs are somewhat irregular in this region, and the humerus left, I can see right humerus shows some lytic areas within it, some permeative abnormality in the
okay, fine. So I would just give some tips that in exam, whenever you look at the X-ray, always is the description of the primary area was fine, I mean fairly good enough. But whenever you look for anything like this, always look at the surrounding bones very carefully by coming closer, a little closer to the film. So if you look at this, I'm not sure whether this, I think this should be visible on your X-rays, this break. And again, this appearance with non-visualization of the ribs here, and the cortex is not visible here and this area. So at least you can see that I cannot see the cortex and the bony margins of the ribs. I would like to review these for any involvement by ongoing process or any metastatic lesions. Then when again you will look for the bones, you will see a lytic lesion in the scapula. It's very clear if you look at this. So if you look at this scapula on the right side, the cortex is here, the cortex is here. As I already mentioned, that look at one structure on right side, then look at the same structure on the left side. Just make this a habit, routine habit, that if you you have seen one scapula, then you look at the left scapula, then you will never miss. But if you keep on jumping from lungs to vessels, vessels to right clavicle, from right clavicle to right humerus, from right humerus to spine, then you will not be able to compare, and you can miss this finding. So and then again, this is another fine, fair enough, the lytic areas are there, no one can deny, but there is again this something is there as well. So you will just describe that there is some soft tissue mass or soft tissue haziness or whatever you want to say in the left lower hemithorax, but I cannot see the ribs, so maybe the ribs are involved, and I also can see some fractures. So I think this is aggressive process, a neoplastic process, and the breast shadows are visible. So there is no evidence of mastectomy, and there is a lytic lesion in the humerus. And keeping in mind these lytic lesions, I would like to review right humerus as well. Maybe there is some pathological fracture with this healing process. So and also you would say that, even you can say me that I'm not able to evaluate the spine nicely because of online session. That doesn't it's not that you cannot comment like this or the film quality, but during the exam, no, you will just look at the positive findings and you will ask it. As a radiologist, we are trying to pass you through that exam as a radiologist who is safe for the patients and who is beneficial for the patients for further management. So you will always say that I would like to see the CT scan to assess the primary origin of this process. I would like to have the bone scan to assess the multiplicity, and then see. So this is the CT scan. So it was nice, just don't worry. The take-home lesson is that you will practice. Number one, you will follow a similar checklist every time when you look at chest X-ray. It's not that you will start differently for every other chest X-ray. You will have a checklist in your mind for a cancer. You will have a checklist in your mind for infection. You have told yourselves that you will look at one scapula, then left scapula, right clavicle, then left clavicle, right shoulder, then left shoulder, right humerus, and it will be just a 1 second review. But then because you are following a methodology, then when you will find anything different from right and left, you will be able to pick that as a radiologist. But if you keep on jumping from humerus to clavicle, clavicle to ribs, ribs to spine, then you can miss the findings, right? So now I will scroll the CT because this case has been discussed in detail. So now you just keep looking at this, right? One. Yes. First of all, obviously you will try to, because there are nodes and this was mass. No one expect you to pick this mass on X-ray. This was not visible on X-ray, right? So then there were multiple lytic lesions in the ribs. This is the same case with soft tissue. Then just look at the bone, and this one, and then this here, So this is also a lesion, and you would like to note, then you will ask, look at the adrenals. I think I have bone scan as well. Let me review. Yes. So just look at the bone scan. So the humerus and all this and the breast, and this is the left. I'm not sure why the scapula. This is the left scapular lesion. Oh, sorry, this one. I'm sorry. I have flipped the image. This is not visible on this, but when you do it the reverse order, then because it was slightly posterior, then this is visible on this film, right? Yes. So that's how you approach. So I hope you know how to approve. Now you will practice one pattern every time for
Yes,
X-ray, right?
Yes, thank you.
Okay.
Skeletally mature patient, showing there is destruction of the right lateral part of the L4 vertebral body along with its pedicle. The rest of the vertebral bodies and pedicles appear normal. Bilateral SI joints are normal. There is evidence of some high density within the pelvis inferiorly. So, based on this, my differentials include, if this is a old age patient, these include metastatic process or multiple myeloma. It appears to be a pathological fracture.
Okay, so how would you like to proceed further?
So next, I would like to do a CT scan. These are images,
just a minute,
images, CT scan.
Yes.
CT scan abdomen with IV contrast of same patient, showing there is a large mixed density mass in the which is extending from the right suprarenal region in the right paravertebral area. This is a cystic density in well, which is involving the posterior paraspinal muscle as well as the psoas on the right side. There is another well-defined lesion in the right lobe of the liver segment 8, which is having fluid as well as high density within it. And there appears to be ruptured membranes inside this. It could be an old calcified hydrate.
Yes, she's right. This was a case of this patient came from Afghanistan, and this was a case of multiple hydrated cysts. And it was one was in the liver and subhepatic, and the other were scattered in the paraspinal, posterior paraspinal, and also involving the bones due to the long staining process with erosive changes. So the catch in the to diagnose the hydrates is infolded membranes within, and then you can always ask for the non-contrast CT to confirm. This was calcification, by the way. You can always ask for the non-contrast CT. So daughter cyst and membrane, multiple infolded membranes within a cystic lesion with calcifications. So if you review some literature articles, there are typical similar cases with erosion into the bones.
And this is also extending to the spinal canal and at some levels. Is this like a known feature of hydrate?
No, this is not a known feature, but if the patient, like from Afghanistan, if they cannot come and they harbor the disease for a very longer duration, so it's a disease, it can go anywhere. Even it can extend in entire skeleton. I remember a poster from in RSP where it was present in every single organ. And yes, you are right. This is very crucial finding to mention, that it is extending into the spinal canal. You will go for the MRI to assess the spinal cord compression, and the neurosurgeon will remove this area to decompress the cord. Any question?
What do we do next for hydrated for exam purposes? Because I heard that pair procedure is now obsolete.
Sorry, I couldn't hear you. Can you please repeat the question?
Sorry, ma'am. Previously, we used to do a pair procedure for the hydrated cyst for its diagnosis. Now that procedure is obsolete. So, what for exam purposes, what would be our next step?
Well, for example, you can say that they will do the hydrated titers or for the diagnosis. And definitely, this patient definitely needs surgery to decompress the spinal cord.
Yes.
And I have seen them removing complete hydrated cyst as one unit if it is causing
Yes,
mass
ma'am.
effect and other problems. But you cannot put a needle there so that it gets punctured and then it starts irritating entire peritoneum. So this is definitely a very supervised surgery, but you can surgically remove hydrated, definitely. Any other question?
Thank you so much.
This is an X-ray abdomen of a skeletally mature patient, which shows there is a large extended bowel loop is noted with hospirations are seen, and I can also appreciate that there is a upstream small bowel dilatation as well, and there is however, I cannot appreciate any evidence of pneumoperitoneum. There is no evidence of calcific density focus seen. So, keeping in view, and it is this bowel loop is seen extending from the right hemipelvis up to the upper abdomen into the towards the chest. And it is obscuring the lower part of the liver as well. So these findings are consistent with the cecal volvulus or other possibility. My most next I would ask for the CT scan with the contrast, water soluble.
Okay, so what is other differential?
Other differentials, ma'am, it can be a closed loop obstruction, but it is and toxic colon can also be included. Toxic megacolon can also be included in the differential, and with the paucity of air distally into the rectum, I cannot appreciate. So, ma'am, these are my findings. And further workup with the CT scan abdomen with the oral negative contrast is suggested.
Do you expect bowel to reach here?
Ma'am,
बाकी लोगों का क्या ख्याल है जब हम एक्सरे देखते हैं तो क्या बॉवल लूप राइट हिप जॉइंट के ऊपर आता है, राइट इंग्वाइनल रीजन के अंदर?
No, ma'am. It can be
क्या हो सकते थे? हर्निया ऑब्स्ट्रक्शन उसकी वजह से हो सकती है, ठीक है जी, तो मतलब वो पॉसिबिलिटी एक हो सकती है. अब मैं आपको इसका सीटी स्कैन दिखाती हूँ. आई होप कि मैं सही स्कैन खोल लूँ, बस 2 मिनट लगेंगे.
Yes, ma'am.
So because एक्सरे पे चीजें सुपर इम्पोज होती हैं, लेकिन एक्सरे को 2, 4, 6 नॉर्मल एब्डोमिनल एक्सरे गूगल करके देखें कि उसमें बाउल गैस पैटर्न कहाँ होता है. वो कभी भी उस जगह पे नहीं होता जहां इस एक्सरे में नजर आ रहा है. सो राइट इन्ग्वाइनल हर्निया था, उसकी वजह से ऑब्स्ट्रक्शन थी, और प्रॉक्सिमल उससे ये वाला सारा डायलेटेड था लूप, ठीक है. तो हर्निया वो दिखाते हैं बिल्कुल एफसीपीएस में भी, एफआरसीआर में भी. एक्सरे से ही शुरू करते हैं, एक्सरे पिक होता है तो सीटी दिखाते हैं. हमेशा वॉल्वुलस ही नहीं होता, वॉल्वुलस बिल्कुल होता है अगर ये वाली चीज एक्सरे पे हिप जॉइंट के लेवल तक ना आ रही हो. तो हिप जॉइंट बहुत नीचे होता है, बॉवल यहाँ पे खत्म रुक जाती है, रेक्टम बीच में आता है, तो हिप जॉइंट के ऊपर बाउल नहीं आती एक्सरे के ऊपर, ठीक है। और इसमें जो एक्सरे प्लेन एब्डोमिनल है उसमें 4-5 चीजें ही हैं। वाल्वुलस आप लोगों को बहुत ज्यादा से आपने उसकी प्रैक्टिस की होती है मेजॉरिटी ने। बाकी गॉलस्टोन आइलियस वो इज इम्पॉर्टेंट, उसमें नीमोबिलिया एंड इस्केमिक बाउल विद पोर्टल venous air is important. Then obstructed hernia with dilated bowel is important. So ये abdominal x-rays के यही कीज हैं। और नॉर्मल एक्सरे में बाउल का क्या पैटर्न होता है, कैलिबर कितना होता है, और डिस्ट्रीब्यूशन ऑफ लूप्स क्या होती है, और एबनॉर्मेलिटी में कैसे होगा। तो फिर डेफिनेटली वो हर केस के लिए, चाहे वो इस्केमिक बाउल है, चाहे वो गॉलस्टोन आइलियस है, और या कि वो हर्निया है विद ऑब्स्ट्रक्शन, वो आपको सीटी स्कैन दिखाएंगे। ठीक है, कोई क्वेश्चन? दोबारा एक्सरे देख लें इनका।
I'm provided with X-ray chest frontal projection of a skeletally mature patient, in which I can appreciate that there is a well-defined lobulated homogeneous opacity in the left hemithorax, which has reduced volume. This opacity is forming obtuse angle with the chest wall, a lateral border, so it is most likely pleural based. However, the ribs at the lateral end within the opacity, they are I can appreciate a break, maybe it's superimposed projectional, or there are some recent lines passing through the lateral end of the ribs. However, I cannot appreciate that this opacity is progressing further into the lateral chest wall. The soft tissues appear normal. Mediastinum is shifted towards the contralateral side. Cardiac cell appears to be enlarged. Left CP angle is blunt. Right hemithorax. It also shows multiple expansilytic lesions within the ribs. It's in the fifth, right fifth or sixth rib. Visualize the rest of the bones, clavicles, they are normal. Right shoulder joint, shoulder joints, they appear normal. Trachea is, however, quite irregular in its outline. So keep in, if the patient is, I would like to take the history of the occupational history of the patient. If there is any exposure to asbestos, then I would like to keep the diagnosis of mesothelioma first. However, I would also like to know if patient is having some known primary, then these could be the pleural-based mets. However, this is less likely to be some lung-based pathology. I would like to see CT chest if available.
Okay, so yes, as some of the examiners, they only show X-rays, so you will say that these are lytic lesions here, and also scapula here, then here, and you can see the multiple punched out lucencies, so you will say metastasis, less likely the lesions are too big for the multiple myeloma, and approach was fine. The lung definitely is abnormal, maybe lung mass with metastasis, so fine, not bad. But for mesothelioma, I mean, you can keep the differential, but I would say lower down, because still the lung volume, there is tilt and portable film, but like in the previous, the lung volume was significantly reduced, and the trachea was also shifted towards the loss of volume side. So so fine, but diffuse osteopenia, multiple lytic lesions, right?
Yes.
Chest frontal projection of a skeletally mature patient. It's a portable chest X-ray in the ICU setting. Multiple chest leads are seen, projected. The cardiac schedule is enlarged, and there is there is a well-defined radio-opacity in the left hemithorax, which is broad-based and forming an obtuse angle with the left chest wall. There is an area of adjacent to this opacity, there is an area of hyperlucency in the chest, which in the hemithorax, which is devoid of lung markings, and which is likely the pneumothorax left.
Yes, correct.
I can appreciate multiple patchy radio opacities in the contralateral chest, in the contralateral lung, with which no zonal predilection, and however there is another large radio opacity in the left lower zone with some air lucencies within. So as okay, now I'm looking at the trachea, which is central, and the bones are being unremarkable. There is an expansile lesion in the right scapula, which is giving a suspicious lesion, having a suspicious look, and this is causing even a step in the lateral margin of the scapula, maybe associated fracture. Summarizing my finding, this is a patient in the ICU setting with the suspicious looking lesion in the right scapula with the right pneumothorax and widespread pleural lesions and a large cardiac shadow. So probably this is a case of right bony primary with pleural mass and a right-sided pleural effusion. However, I would like to confirm my findings by going to the further advanced modality, probably the contrast enhanced CT scan, and for the multiplicity of the lesions, I would also like to go for contrast enhanced CT scan chest abdomen for the further evaluation, and the bone scan for the osseous lesions.
Okay, so fair enough. This film is nicely described and will be passed in any exam. So whenever you see such films, you will look at the tubes, position of the tubes, and this one, and then this chest tube. Third, these are ECG leads. You can ignore these. Again, ECG leads can be ignored. And then with all these findings, the bony lesion, again, the key is the same. Look at one scapula and other scapula and pick the findings. So this was definitely metastatic lesion. So fine. Okay. So let's move to the next case. Please, because I'm not reading the chat, if they have any question, just give them my email address. I can reply at individual level if any remain unanswered during the session, because they are sitting this late. So I just don't want them to have some questions in mind which I couldn't answer. So I'm available. So let's move to the next case.
Madam, please tell the diagnosis of this case and also the location of tracheostomy, ETT. They are asking.
Okay, so I will be honest, seriously, I don't remember the diagnosis, but definitely this was a metastatic lesion. But what was the primary? I don't remember. I think it was some osteosarc or something, and that has resulted in pneumothorax. and with other metastatic lesions. But that is what I can recall from my memory, but I don't know the exact words in the diagnosis. And the endotracheal tube is not, the lower end is not very well visible, but it's definitely above the carina. I think it ends somewhere here. So if it is, how much? I think 2 to 3 centimeter above carina. Yeah?
5 centimeter.
5 centimeter above. I think I remember 3, but for portable, but maybe 5. But practically, when I look carina here and the tube at the level of clavicles, then I say it's normal.